Good afternoon for those of you on the East Coast, and good morning for those of you on the West Coast. The Clear Health Quality Institute webinar will begin in about 30 seconds. Looking forward to today's discussion. Hi, welcome. My name is Gary Carneal, and I'm the founder of Clear Health Quality Institute. And I'm looking forward to moderating today's webinar, which is entitled Accreditation, Developing a Blueprint for the Future Assessment and Evaluation of Telemedicine Quality. I tell you, I'm quite excited about today's topic. I've spent a good portion of my career bringing to market well over 20 different accreditation programs in healthcare. And when you have something as important as telemedicine emerging in terms of changing practice patterns, providing new opportunities for care through virtual connections, it's quite an exciting time. So a lot of today we'll be discussing kind of where we're at in terms of setting standards, moving forward with quality benchmarks, and other things. A couple housekeeping items before we start. This is the second of 3 webinars that Clear Health Quality Institute has planned for this year. Information regarding the upcoming session and the recording for the first session are available at CHQI's website, which is www.chqi.com. This webinar also will be recorded with a link to the recording that will be emailed to all registrants within the next few days. Attendees will be muted during the webinar, but we encourage each of you to submit questions via the chat window in the GoToMeeting webinar platform. These questions will be addressed at the end of the presentation, time permitting. So as we kind of set the stage for today's webinar, we're at this really, I think, important juncture in terms of the growth and expansion of telemedicine. And there's been a lot of recent activity over the past year or so in terms of beginning to identify a more enhanced quality framework, the establishment of several accreditation standards and outcomes-based measurements, the beginnings of more standardized data reporting, and public policy discussions about what's the proper role of a regulation, how prescriptive we should be, and basically in the day, how we promote value-based purchasing, ensure quality, and making sure that best care is getting to the patients at the right time. We're very fortunate today to have 2 very seasoned experts join us, and I'll introduce them in order of their making their presentations. First, we have Clarence Williams, who serves as the Director of Telehealth and is the primary leader responsible for leading the growth and development strategies for Mercy Health Networks. He's in charge of the growth and development of all telehealth, e-health, and virtual health solutions across MHN. His focus is implementing and strengthening telehealth programs that meet the goals of our patients and providers. Mr. Williams supports the work of owned and managed affiliates to identify priority programs, leads the assessment of new programs, leads and supports the implementation of new programs, evaluates new and existing programs, and guides successful programs for long-term sustainability. Mr. Williams joined MHN in the spring of 2016 and currently serves on the board of directors of the Iowa Rural Health Telecommunications Program. I should also note that Mr. Williams serves on the CHQI Telemedicine Standards Committee over the past year, and we're very appreciative of that. Prior to joining Mercy, Mr. Williams worked for the Department of Veteran Affairs and spent several years building and sustaining telehealth programs in Veterans Integrated Service Network, VISN 8. In addition, it's my pleasure to introduce you Dr. Darkins. He has a very long resume in the field of telemedicine, so I'll just make some highlights. Dr. Darkins is nationally and internationally recognized for its achievements in building virtual care networks that increase access to care, reduce the cost of care, and ensure the quality of care. After qualifying as a physician for Manchester University Medical School in the UK, a fellowship of the Royal College of Surgeons of London, and accreditation as a neurosurgeon, he experienced firsthand the challenges of care delivery from traditional brick and mortar assets when acuity of patients' conditions and distances from care impact mortality and morbidity. He then launched his career in telemedicine. He was recruited by the U.S. Department of Veteran Affairs in 1999 for his unique skill sets. He and his team created at the VA, built the largest and most sophisticated telemedicine telehealth programs in the world. By 2014, when he left the VA to join Medtronic, over 600,000 veteran patients were receiving care annually via VA's national telehealth program that served all 50 states, Puerto Rico, and the U.S. Virgin Islands. On any given day, over 90,000 veterans with complex conditions, chronic conditions, were able to live independently by virtue of technology-assisted care coordination programs. The care case management services these programs provide use remote monitoring technology to risk stratify patients according to acuity and proactively intervene to reduce hospital admission and length of stay. Dr. Darkins also has served as Vice President of Innovation and Strategic Partners at Medtronic, as I mentioned before. He also has served as or is also actively involved as Deputy Chairman and Non-Executive Director of MediBio, a company developing predictive algorithms for diagnosis management of mental health conditions. He's a trustee of the Swinfin Trust, a charitable organization providing humanitarian assistance via telehealth to over 70 countries and much, much more. I've come to rely as well with Mr. Williams, Dr. Darkins, on his advice and counsel in terms as we move forward with CHQI's accreditation program. He's certainly thought of as a national expert in so many areas. So today, I'm just going to spend a few minutes giving you a background on two initiatives. One is, by example, Clear Health Quality Institute's new telemedicine accreditation program, which launched in conjunction with the American Telemedicine Association, and the recent work of the National Quality Forum in establishing a outcomes framework, and I believe Dr. Darkins served on that committee. Mr. Williams will talk a little bit about his experience as a Mercy and a more kind of comprehensive, integrated and dynamic hospital system. And Dr. Darkins will talk a little bit about system design and some of the broader perspective we need to make and implement to optimize the opportunities with telemedicine. And then I think we're going to have some fun with a round-robin Q&A. So just real quickly, Clear Health Quality Institute was founded just over a year ago, and among other things, we are functioning as a classic accreditation agency and have just launched telemedicine standards back in March that you'll see in a moment have a fair degree of fidelity and create a typology of three different areas of telemedicine encounters. One is consumer to provider initiated, and that includes things like doctor triage or nurse triage services when the patient or consumer calls an online provider for advice and counsel. Provider to consumer, which could be something like telepsychiatry or case management, something where the provider engages the patient or consumer into often a longer term relationship. And then provider to provider, which could be something like teleradiology or other types of specialty consult services. But what's interesting is that the Standards Committee for CHQI, with the support of ATA, began meeting in June of 2017 and met up through the beginning of March of 2018. And part of identifying the use cases was a very important part of the discussion in terms of really what is the scope of telemedicine, what's the difference between telemedicine, for example, and telehealth. You know, what's virtual treatment, what's virtual care. So I'm sure we'll talk a little bit more about that. But this actually comes from our standards and kind of shows kind of the existing typology of what at least CHQI's accreditation programs cover. And much like many other accreditation programs and pursuant to like the ISO 9000 tradition, there's a set of core standards which CHQI has drafted and implemented, which covers things like basic business requirements, making sure the organization has thought about the scope of its services, making sure it has proper organizational capacity, that things are documented in writing, making sure that it's clearly delineating and identifying what actually telemedicine modalities and technologies it's using. It goes on to discuss in section 2 a little bit about the professional oversight, making sure there's both business and clinical and technological oversight in terms of all aspects of the telemedicine provider. And core section 3, making sure that it has the traditional quality management activities, making sure that additional precautions are taken because of the virtual exchange with the patient who is at the originating site and the providers providing telemedicine services at the distant site, making sure there's not only consent in terms of the treatment, but through the modality of treatment, that being virtual care, patient safety, equipment safety, and making sure there's a organized complaint and appeals process when there's a problem. Section 4 deals with clinical workflows, addressing things such as clinical service lines, the patient clinical history, workflows associated with triage and treatment, infection prevention, and online e-prescription or online prescribing. And finally, the core section 5 deals with risk management issues, everything from regulatory compliance to dealing with facility protocols, protected health information, emerging management, making sure that there's certain transparency in terms of patient billing, insurance coverage, and commercial disclosures. And then you drill down into the specific modules. An applicant can apply for 1 to 3 of the modules, depending on their scope of their services, but the first 6 or 7 standards are pretty much the same with each module. It just goes into more detail. What are your program goals for your specific use case and telemedicine action, making sure you have sufficient provider capacity, making sure that you have more defined clinical procedures and workflows associated with that, making sure that there's proper technology proficiency for all the users within the system, and then making sure that the patient-provider relationship is defined under consumer to provider, and making sure that the same thing is held true for provider to consumer and provider to provider, just making sure that all the parties involved in the transaction know their roles, such as with provider to provider, making sure there's one primary physician who's basically making the referral down to the other provider, making sure they understand their roles. Obviously, for all 3, continuity of care, although some types of telemedicine transactions may be more episodic, you still need to think that through and make sure there are proper handoffs when that's permitted. And just making sure for consumer to provider that you're really thinking through the patient-initiated encounters and making sure the patient is taken care of throughout the process, and there's appropriate follow-up, again, based on the scope and duration of the telemedicine encounter. And then a little bit more thinking on provider to consumer and provider to provider, think about the populations that are being served. And then for all 3, dealing with kind of telemedicine outcomes, which deals with, at least having one outcome measure related to operations, clinical, and patient safety. And then finally, there's the notion of a demonstration overview, which basically provides an online kind of review of the key workflows and audit as part of the accreditation process. So you think about that as one example of an accreditation program, and there are others out there that offer similar services. Then you have the work, for example, National Quality Forum, which was published last fall, that's creating framework to support measure and development for telehealth, and it basically came up with a framework that had these 4 domains related to access to care, financial impact and cost, experience, and effectiveness. So this kind of sets a placeholder, and part of what we'll talk about today is how do you take something like this as a conceptual framework and kind of move it to practice. So again, setting the stage, we have accreditation, which often involves process and structure measures. We have this debate that's picked up in a lot of the accreditation efforts and NQF about outcomes, which potentially translates to more clear metrics and potentially value-based purchasing networks. So I'm going to call on Mr. Williams now to talk a little bit about his experience at Mercy Health Network. Clarence.
Thanks, Gary. Um, Again, as introduced, Clarence Williams, and I oversee the telehealth initiative there at Mercy Health Work. And just to put it in a perspective about who we are, we're a joint operating agreement between Trinity Health and Catholic Health Initiatives. So we have two parent sponsors who cover multiple states, about 20 or so states apiece. And then there locally, we have about 15 or so owned hospitals, and then a number of managed affiliates. Numbers about 27 to 30 at any given time. So our landscape is vast and diverse in terms of information systems, governance, operations, sort of local strategies, payer dynamics, and the list goes on. So one of the things that we really have focused on is how can we leverage quality framework that can really speak to the entire organization, given our complexities and all the nooks and crannies of being in a large major health system that has two parent sponsors that at times can have some competing priorities or frameworks. So to that end, one of the things that we leverage telehealth to do is to reduce cost, in that we have a number of subspecialists within our system who spend a lot of time on the road traveling out to rural Iowa. So if you can imagine pretty much the center of the state where you see the three crosses in about a 2 or 3 county area, that's where most of our subspecialists pool, especially those who are owned. They spend a lot of time traveling to those various communities, some of which have their own subspecialists that have a lot of windshield time, and they're traveling out to affiliates that are in our network or an independent organization. So another thing that I think we have the opportunity to do in terms of a quality framework for Mercy Health Network is really taking advantage of the diversity that we have and the perspectives that are represented. For example, we have freestanding rehab hospital that opened this month. They're in Des Moines. It's the only freestanding rehab hospital for physical med and rehab in the state. We've also we're moving forward with another freestanding psych hospital that's going through the certificate of need process. And then we have a number of other capital assets, some of which are newer in the urban markets, and others are reducing their footprint, as some of our critical access affiliates might have a low daily census, maybe 1 or 2 patients per day on the inpatient unit, but they have high emergency department and subspecialty or outpatient clinic volumes. So there's really a mixed strategy as far as sustaining the viability of many of these communities and the health systems using virtual care. And so in terms of quality framework, if you can imagine sort of being in my shoes, having to deal with 45 or so different executive teams, 45 or so different med staffs, quality managers, CFOs, CNOs, and the list goes on, it's really helpful to have a framework for quality that covers both vendors as well as programs that we have a hybrid or we start from scratch, inpatient, outpatient, and or direct to consumer. And that's a lot of the value that we perceive in a CHQI framework, in that we can apply this to our direct to consumer offering that we may or may not staff ourselves depending on the market. We can apply it to some of our inpatient programs that are a bit non-traditional. We have a very large and successful ACO, value-based contracts. We can resell some of our services to employer groups as well. And then we have the traditional set of clinic-based telehealth that's in a medical setting to meet payer requirements. So I'll pause there and see if if you have any maybe questions about what makes sense for us and how we specifically use the CHQI framework.
Well, so let's do this. Let's have Dr. Durkin make some initial comments, and then we'll turn over to the questions. But yes, I do have some questions related to that. So Dr. Durkin, do you just want to make some of your initial observations from your perspective?
I do. Well, thank you very much. And Hello to everybody. Good afternoon, those on the East Coast, and good morning, those on the West Coast. And I'm speaking from Toronto. I'm very excited about the movement towards standards in telehealth. As mentioned when I was introduced, my background was having developed very large telemedicine telehealth programs at the US Department of Veterans Affairs. It was a great privilege to be there and to do really unique things. When I started, the programs were small, and really the challenge was to move from pilots to really large-scale production delivery of telehealth, which is something which lots of programs are now dealing with. So the lessons I've been sharing in the role I now have been largely around that. So I'd like to take you a little bit back through the history of some of the things I've been associated with, because I think they're valuable just to be able to mention to you. When starting out, I think some people may not realize that back in the early 2000s, there was still a feeling in the telehealth programs that telehealth was essentially very similar to just doing face-to-face consultations. And when we started out, there was really a big question about why would you need to do standards? And in case people are out there wondering what the value of standards is, I thought I'd share why we introduced standards within the VA as we were building out, when there weren't really much in the way of standards at all, other than just associated with credentialing and privileging. I want to just pay tribute to the amazing people I work with. The work I'm just going to describe and some of the lessons were linking to Linda Foster, who was one of my colleagues developing the quality framework, and Carla Anderson, and also Len Goldschmidt and Jerry Selvin. This was something which has kind of worked over several years. Dealing with quality standards really arose to the fact that we were taking programs to scale, and these programs were mission critical. So in moving from a pilot to production, one of the measures of doing so are these mission critical services which people depend upon, in which case quality comes to bear because of risk management. It also is important in terms of the value proposition for what one is doing. The quadruple aim in terms of cost and quality and satisfaction to patient and to provider, one has to really assure that these are being met. And establishing standards is of critical importance. My particular belief is that the importance of networks as you develop telehealth programs. The value is how you provide services across different sites. You make services convenient for the patient. In order to develop networks, it is important to have associated standards. You can only build a program to a certain level of scale based upon relationships. And then if you don't have standards in place, one finds that things end up being problematic and having troubles. So the standards that need to be in place, in my experience, cover three domains. One is clinical standards. The second is associated with the technology itself. And the third is in relation to the business standards, which are in place also. I really applaud the efforts, of which there are several at the moment, which are being done in terms of standards for telehealth. And really in their initial phase, they replicate many of the things that we did back in the VA when we started doing standards, which are really to make sure that very basic processes are in place. They're almost, I think, to put it bluntly, housekeeping, to be able to make sure everything's done in a clear and consistent way, to be able to make sure that things which are legal and regulatory are covered, and they're really the basic foundation. But I think there's another dimension to standards, which is also around, they help one build out a network. So there's a creative element to how do they assist you in taking what you're doing forwards. Because essentially, in order to be able to create large networks, the various processes, the clinical, the technology, and the business I just mentioned, have to be interoperable. In the VA, we develop programs in 150 hospitals and over 700 other sites of care. To be able to develop such networks and really to leverage clinical services over an entire country one really has to be able to make sure that it's quite clear and consistent what's being done. So let me give you just a simple example. If one's developing video consultation between hospital site and a remote clinic, if it is that in the beginning of that consultation, it's not clear what the standards are that relate to informed consent, and the patient is in a small remote clinic, and the very first thing starts with the clinician providing the care, talking to the person at the other end, and not clear about informed consent, then it's really, from the patient's point of view, very discouraging if they don't feel that there is that kind of seamless delivery of care. So there's a way in which implementing standards, being able to do things in a consistent way, mean that one can develop and leverage these services in the way that I've just described. Having done that and having got these processes in place, I just want to say a few words about the fact that the challenges are often in implementing. So as we're seeing standards evolving and begin to be in place in telehealth, I mentioned how really we've gone from a situation 15, 17 years ago where there was no particular call for standards. People didn't see why, what was different, to now being very much these initiatives to be able to put them in place. Healthcare has large amounts of standards already in place in a whole range of areas. So one of our challenges was, how did we do this in a way that integrated with existing ways in which quality standards are managed? Healthcare has quality standards which are for all existing services. So one wants not to be able to replicate what's being done. How, as far as possible, do those standard setting processes use existing staff? Or if they don't use existing staff that are doing quality standards understand what's going on so there's no confusion, and really don't replicate efforts. I've mentioned really that how important it is to think about interoperability. So as we move forward, it depends really what the vision for a healthcare system is, whether that's a localized healthcare system, which is trying to build services within a state and leverages services around a state, or whether it's beginning to develop national services or national services are in place. These being interoperable are really important. If services are not interoperable in terms of the clinical care delivery, in terms of the technology itself and the business processes, it really limits their ability to be able to scale. What I'm really coming around to describing is essentially systems design. So I think that as these programs are developing and moving out, seeing oneself as part of a system is really important. And many of the aspects related to design of systems are much easier to build in as you begin to develop the network than find you're 2/3 of the way through. And in building out those networks, you find that standards then need to be retrofitted. So the importance of strategic planning. So the few words which I just want to finish with are just really saying, in case people are feeling that telehealth was originally around really this open area where it was very creative, it is still and will always remain creative and be able to develop really exciting new services of delivery of care. And the opportunities to be able to do value-based care, bundled care, and new payment models, I think, are extraordinarily important in terms of where things go forward. The development of standards is really, I believe, acknowledging the maturity of telehealth now and taking it from this stage of having previously been pilots which are moving to a certain level to really becoming an intrinsic part of healthcare delivery. And I think that in doing so, it's really important that there's feedback. So as we move towards the question session, my experience of developing these standards is not a top-down approach, where essentially they're imposed from above. It's really working very closely with those who are involved in implementing the standards, getting feedback and adjusting these and using as a way to really grow the networks in healthcare as it's going to be in the future. And I think one needs to just remember that in order to provide a business case, if we implement telehealth, which essentially delivers healthcare in the same way as is always being delivered with technology on top, it's going to impose extra costs. So inevitably, telehealth is around about how do you re-engineer and how do you deliver healthcare in a different way. In doing that, there's creativity and there's the necessity that we actually work together. So I'm going to stop. I just wanted to say across the board, finishing, that these standards, again, I think are really important. The various initiatives that are going on in terms of the maturity of telehealth, and that its growth is going to be very much an interactive process, which those are implementing and using them together with those who are creating them. With that, may I pass back to you, Gary, and look forward to questions, and I can answer in more detail some of the specifics of some of the issues around how you implement some of these programs.
Well, thank you, Clarence and Dr. Darkins, for your great initial comments. I mean, my head is spinning with many thoughts, and it's humbling when you think about if you're working with an accreditation organization, you're in the business of setting standards. But to your point, Dr. Darkins, it's much more than just a top-down approach. We live in the United States with this incredible ability to incubate new ideas and innovations in healthcare, and there's just so many different kind of moving parts to basically move, as you described, from kind of relations to a more systems approach. And remind you of that, Clarence, with Mercy, in terms of how complex and dynamic your life is day to day in terms of managing your telehealth offerings. So I thought a good initial lead-off question would be, really, as we're sitting here in the rise of telemedicine, it's definitely one of the hot trends of the day. And I think back in the late 1990s, I was running another accreditation organization, and I brought to market through some great help through some experts in the field, through several standards committees, what we now think of as a telemedicine or telehealth transaction. In the late 1990s, worked on health call center standards, nurse triage standards, case management standards, which were more telephonic based. So I think just we kind of set the stage in terms of today. Obviously, we're thinking about this in a more organized approach, but prior to recent times, how did the VA or Mercy or other telehealth providers actually design, implement, and evaluate telehealth programs historically? What were the reference sources? How did this all kind of get to the point now where we're at the almost perfect storm of opportunity?
Well, Gary, I can speak to Mercy Health Network's experience. Prior to my tenure, Mercy participated in CMS's telehealth demonstration project in the 90s and had been a part of that conversation at the forefront of kind of legitimizing and rapidly expanding telehealth since that time. And so many of those best practices and many of those workflows and standards were developed from scratch using other organizations or other frameworks from accrediting bodies or systems, if you will. And since that time, Mercy has continually built upon those programs, some of which are still in existence today, as far as increasing the technology, having a voice in many of those rural health forums in the tech space as that also develops, as well as the policy world. Many of my successors have participated in telehealth policy conversations since the 90s, both federally and locally, and have really helped to drive that conversation with the Iowa Board of Medicine, the Iowa Board of Nursing, the Iowa Board of Pharmacy, and actively participated in developing some of those standards.
Great. Dr. Darkins, any comments?
Yes, I mean, I think I mentioned before that really the drive for telehealth standards within the VA came out of the need to expand the programs, and really it was part of a realistic desire to go to scale. So it fits in very much to risk management. And the VA, I was very privileged to work in the VA in terms of taking some of this work forwards, because the VA really has got a reputation and a track record with people like Dr. Jim Bajan of really having developed groundbreaking risk management and other programs. And so it was very easy with that kind of background to work in an organization like the VA, to work closely with organizations such as the Joint Commission. So a very specific concern that I had was that when we set off in 2003, 2004 to develop telehealth networks which are going to care for 100,000 people in their own homes, tens of thousands of people who are going to be having video consultations, and hundreds of thousands of people who are going to have store and forward consultations, a concern that even though there weren't telehealth standards and accreditation in its own right, particularly at the time, the fact is that other accreditation bodies do work in healthcare. And the Joint Commission, with its tracer methodology, was going to be at the scale we were doing telehealth, actually seeing telehealth consultations taking place and evaluating them. And if they weren't done within some kind of formal schema that made sense of how they were being done, one of the dangers might be that telehealth, if it was done in a less organized way and less standardized way, could have raised alarms for an accreditation organization. So if such alarms were raised and there wasn't a systematic way in telehealth was being done, we could have put both the organization itself at risk in terms of services being provided and the particular programs related to telehealth. So that was really the background for doing it. There wasn't a history at the time of particular standards that were in place. They were rather limited. So again, very fortunate to work with an organization, to be able to link into other organizations such as the Joint Commission, to be able to really have a dialogue with them about how we move forward. So I think that my sense would be, and I'd be interested in your views on this, Gary, I think that there has tended to be a view that standards and standard setting organizations are rather sort of big brother or big sister who's kind of imposing from above. In my experience, it was really important this was a dialogue. We were moving into new territories. We're doing so. It was very much easier to talk about it with standard setting organizations, accreditation organizations in advance. So there was really communication understanding than trying to resolve things later.
That's great comments. I mean, I'm thinking, Clarence, about kind of your comments about, Mercy's working with CMS, and Dr. Darkins, your point about, working with standard setting bodies such as Joint Commission that have had such a strong historical perspective in terms of influencing workflows and quality standards and, what the balance is. So I think, that is a good segue into our next question about telemedicine oversight. On the one hand, you have these virtual treatment and care encounters that transcend traditional thinking of regulations for, let's say, licensing, for example. So obviously, when you're doing interstate care virtually, that challenges some of the traditional licensing statutes. And I think, the question is, what is the role of telemedicine regulation at both the state and federal levels, and how can accreditation help? And what other types of mechanisms like purchasing criteria? How can that all be balanced out to provide us a forward trajectory, but without becoming too prescriptive or too dogmatic? Thoughts?
Maybe I should go first this time then, if I may, Clarence. I certainly have never considered my role in the past, and don't do now, to actually be to set regulations either at state and federal level, because I've not been in that position to do so and wouldn't like to comment particularly on what needs to be done. From my point of view, I think that it's very clear that from a risk management point of view, that if we're trying to grow programs at scale, then it's important that one adheres to regulatory requirements. And so in adhering to regulatory requirements, as you build out standards, it's important to make sure they include those elements and make sure they're included. There are aspects where as you move forward, you can find that there are grey areas because one's actually doing things in ways they haven't been done before. So let me just clarify. In my experience, in my opinion, healthcare accreditation, healthcare standards have traditionally been linked very much to a physical institution. So very much around a hospital or a clinic where services are being provided face to face. Traditional accreditation and standards weren't really developed with the idea of how you would accredit networks where services were taking place across multiple different sites and virtually rather than physically. So in that sense, there are times where ambiguities and questions and doubts get raised. My own particular belief is it is better to approach those proactively, to talk to the stakeholders at the federal and the state level in advance, again around risk management. If you're going to make big investments which take place in services, you don't want to find you're at risk having developed them with your business plan rolling out because you didn't comply with standards. And I think that that's, again, the importance of the various standard setting groups that are being established is part of their role to provide that interactivity to be able to link in policies as it goes forward. So I would just say that I think that it's really important as these things move forward and in resolving things at the state and federal level. If we're going to get the kind of telehealth networks our society needs, it's important we develop standards and operability within the standards themselves. I think if we have 6 or 7 different sets of telehealth standards, the whole area is going to become confusing. So I think this is really around an exercise in visioning of what the future is going to look like and making sure there are really those kind of discussions in advance as we roll forwards.
Great, thank you. Clarence, any thoughts about oversight?
Absolutely. In my experience with being a JOA between Trinity and CHI, a lot of our collaborations with other markets in either parent sponsor oftentimes operate across state lines, meaning that, you know, we can multiply the complexities of really leveraging the benefits of being a health system in that we have maybe some capacity or expertise in one market or another that we can maybe use to deploy access to care or increase the quality or some service that's not available, or physician consultation that's not available within our own network. And so in those conversations, we oftentimes evaluate the state regulation and the federal regulation and kind of the gaps in there. And then with that, those local operational bodies, such as local med staffs, have to be educated and better understand sort of the detailed approach that's necessary to complying with the various regulations and state laws and federal laws, as well as payer credentialing issues and payer policies. And so I found the benefit of regulation at kind of juggling both state and federal is that it gives us an ever-moving current by which we can sort of gradually improve the quality of our conversations about deploying sustainable system-wide telehealth programs. Many of these conversations are directly involved with local legislators that were a byproduct of collaborations with my peers in either parent sponsor system or working with a local med staff or particular representative or a commerce subcommittee or a health and human service subcommittee member, sort of leverage those regulations and help us gradually expand our footprint, given, you know, the decreasing capacity that we're experiencing in rural Iowa and other parts of the country. And so the value that I see with accreditation is we have a legitimate means to leverage, you know, this set of criteria we're using to develop our program. So in those conversations with the payers who might be looking at prescriptions and the validity of those prescriptions that are originating from direct-to-consumer products that we're partnering with, or emergency department-based telemedicine programs, or any other type of use case, it really gives us an ability to scale, knowing that we have moving targets across the country as far as state regulation and the federal regulation conversation is ever expanding.
May I make one other comment, please, if I may, Gary?
Of course.
One thing which I failed to mention, which I think is really important just to add, is in healthcare, really one of the fundamental precepts is to do no harm. And we haven't mentioned so far, and I just wanted to stress the importance of the fact of patients, and that healthcare is really is that it's a way to deliver healthcare in new ways which are beneficial to the patient. If it works well, then one of the side products is often the staff who are involved in telehealth. It takes them back to why they got involved in healthcare, to be able to really improve the care of patients. So within that framework, patient safety is really at the heart of it. So I think, again, one has to view the history of standard setting and accreditation very much around patient safety. And so I just wanted to stress, so often one can have conversations in healthcare where patients don't get actually sort of mentioned. I think what's really important in this field as it evolves is how we engage also with patients, because there has been a tendency for systems to be very paternalistic and to decide what needs to be done for patients, and quite how the link into patients, the patient perspective is added, I think is a really important question as we go forwards.
Great point, Dr. Darkins, and I know, listening to the CHQI Standards Committee, that was a major focus, just to make sure that the patient and consumer was, the center point as for all, telemedicine type related transactions. So Clarence, building upon your comments before in terms of the kind of regulatory oversight, what's your kind of vision point in terms of potentially how a system like Mercy, this is probably just kind of expanding upon your earlier comment, could potentially rely on an accreditation program like CHQI's for telemedicine, or as it's applied to particular use cases, how do you ensure the quality standards, or since you're, a complex organization with multiple stakeholders with probably multiple expectations and needs?
Great question. Oftentimes our risk managers and quality managers are used to using hospital-based standards or clinic-based or ambulatory organization types of standards. And in some cases, our telehealth programs might fall outside of those accreditation frameworks or those quality frameworks. And so we're left with a void of med staffs or quality managers, for lack of better words, maybe overreaching, trying to apply standards that don't necessarily apply to direct-to-consumer types of programs, for example. And so the value of the standards is it allows us to fill in that gap and oftentimes provide a tool by which we can use across the system to evaluate quality and enhance any standard framework that those local organizations might have. So it gives us that baseline level of framework. And some organizations that we manage might add to that framework, just depending on their local operations or maybe some of their own constraints or strengths within their local systems. To further add to that, our affiliates generally are either accredited by Joint Commission or the State Department of Inspection and Appeals. And the Department of Inspection and Appeals is really geared toward rural providers, critical access hospitals, rural health clinics. And so those standards, I think, speak to the nature and the day-to-day operations of those administratively lean organizations in rural Iowa versus some of the more traditional, robust hospital types of accreditation. So being able to leverage this accreditation standard framework allows us to balance between what's reasonable as far as measurable and trackable quality framework for both extremely rural and these larger, more sophisticated organizations that make up our network.
Great. So the good news, Dr. Darkin, is that there are a lot of standards that are helping, kind of create a more logical and system approach to the delivery of telemedicine services. The bad news is that there are a lot of standards that perhaps, create some confusion and with so many different types of telemedicine programs. Is there any way that we can kind of move to a more standardized framework or actually identify standards between the different standard setting bodies or regulatory bodies that can create a little bit more uniformity to kind of further accelerate what the best practices are, particularly as we think about it from the vantage point of the patient?
Well, my role, what I do is really help organizations to be able to strategize how they're going to take telehealth programs to scale. And by scale, I mean a meaningful scale which is sustainable. And standard setting, for all the reasons I described, fits into it. Now, this is a kind of new area, so I find I already mentioned there are several different sets of standards. And personally, I'm somewhat agnostic in terms of what they are. So I think that looking forwards, there are various ways this may well play out. One of the ways it'll play out is if the standards are appropriate and beneficial to building the industry, then one of the tests will be whether very large networks are established in the way they need to be established. If they're not, then they need to be really responsive to be able to work towards that. I think that current restrictions in developing telehealth networks that limit many of them to state levels means that there isn't really a need to develop large networks outside state levels at the moment, though some of that does take place with multiple state licensures, etc. But if for a moment I maybe excuse kind of visioning into the future, I think the vision for the future is going to be very large networks of telehealth. My supposition would be that in caring for people with chronic disease, for example, who have remote monitoring, they're not going to be happy with if that remote monitoring means that they're not clear they're getting services they move outside the single state. People travel nationally and internationally, and if the fact that the remote monitoring you have is providing critical services to you to keep you living independently, one is going to want those services to go with you. So I think there's inexorably going to be a movement over time towards larger scale networks and interoperability to allow that to happen, to really allow people the benefits of the mobility that telehealth is going to give them is going to be important. So how that's going to come about, I think, is going to be, either it will come around through pressure or it'll come around through attrition of programs that aren't standardized, or attrition through standard setting measures that don't really harmonize towards those ends. So I think there's a market approach, or there's a more policy and discussive approach. So I'd almost throw that back to you, Gary, if you don't mind, as the moderator, to say, I'd be very interested to hear from you what you think would be the process whereby this is not going to be, as, if you'd like, many sets of standards, but perhaps what's the strategy that you feel towards that kind of both national and international standard setting in the future?
Well, that's thank you for throwing that back at me. It's funny. One of my roles is I serve on the board of a national employer group called the National Purchasers for Healthcare, and we work on a national RFP. It's called Evaluate, where we're trying to standardize where we can. And I think clearly when we look at the tradition of, let's say, HEDIS, or when Joint Commission offered ORIX, when you convert that to outcomes performance measures, I think there's a convergence of some of the diverse process and structure measures into kind of a more organized approach, which I guess today is often expressed as kind of value-based purchasing. I also served on another trade association where I led an initiative assessing value-based purchasing initiatives for health plans and managed care organizations. And one of their, they liked many of these programs, and obviously it's a great way to, whether it's coming through a large public payer like CMS or a large employer, it's a great way to effectuate social change. But they noted one of the feedbacks in the paper was that there's still, hundreds of different value-based purchasing initiatives. So I think the question is, if you're looking at something like the NQF framework, or the different process and structure measures that are part of the accreditation tradition or regulatory traditions, those of us who have some knowledge, have kind of responsibility to kind of think this through. And ultimately, I guess going back to you, Clarence, in terms of the diversity of the populations that you serve, I mean, how do you balance this need for customization versus standardization, kind of as you think about the different telemedicine programs that you supervise and oversee?
Yeah, so I generally sort of think of our programs in two ways. One way is sort of local programs or very specific use cases, maybe one-offs. There's a provider looking to do a certain type of program in a limited market. And the other pool would be service line level programs. For example, if we're looking at lung cancer screening and we're going to roll that out across the network, or rehab or cardiology, those are the type of programs that we really try to, I think, standardize the workflow and the operation, since both programs, both individual one-offs and the service lines, are kind of grassroots driven. These ultimately are requests coming from rural med staff or med staff at some of our larger hospitals. And so having that balance gives us the opportunity to sort of glean what either parent sponsor is doing in terms of value-based purchasing on the CHR or the Trinity side, and then what can we do there locally to help leverage our strength in numbers to also apply that to telehealth and have as much of a standardized workflow and set of quality metrics that we can possibly have without overreaching. So I would say it's really a balancing act between our competing priorities in terms of one-off use cases versus programs that operate as a service line.
Can I make a quick comment that preempts your next question, if I may, Gary? I'm just going to say that.
Sure, absolutely.
I think that one of the issues here around standardization really fits into value-based care. Having done a lot of work developing value-based care programs using telehealth or telemedicine, very simply, that if you want an outcome, you have to measure the difference between input and output, and that's where the value is. The value is really that difference in health status and cost between the two. If you're not clear the process between those two measures is consistent, then you can't be clear you can attribute the outcome. Now, we have a very variable healthcare system, and if telehealth programs are inordinately variable, then the variation in quality and cost across them makes it very difficult to assure value. So I think that the whole issue around quality systems are really intrinsic to how value-based systems get really introduced and implemented in telehealth.
Fantastic. I know we're running out of time, so I'm going to ask my colleague Julie Irons to chime in if there have been any questions that have come through the chat room, but as she's kind of queuing up, I did want to let you all know that this is what's so exciting about developing standards. And among other opportunities I'm sure you have, CHQI would love to invite any of you to participate in our various standards committees, and we have a brand new accreditation committee where this type of discussion often takes place, where we're really talking about, because the most important thing is that we continue kind of this public policy, clinical and business dialogue to really make sure we're providing the guidance to make sure telemedicine and telehealth stays on the right trajectory. And one of my other projects, I support a large nonprofit that's promoting mental health parity. And I'm just struck with, for example, how in terms of the pursuit of health equity, approximately 1/3 of all telemedicine transactions are related to behavioral health. And so that provides a clinical leakage point where there's a shortage of mental health officials pretty much throughout the United States. And by extending the reach of telemedicine behavioral health interventions, we're really kind of adding and helping out on many fronts. Julie, any interesting questions coming in the chat room? I have a number of other questions, but I just thought I'd give you a minute or two to see if anything came in.
I've got one question asking about who should the participant talk to about state standards, and who should they talk to about federal level standards?
So in terms of, that's a good point that we have multiple levels of government, multiple levels of telemedicine types of operations. Some are local, some are statewide, some are regionally based, some are national. And again, I often think that, coming from the ground up versus the top down, pursuant to Dr. Darkin's comment, that there's a lot of innovation ideas and that come from the actual field of telemedicine. How that it gets expressed both at the local, state, and federal level becomes very, very important, because if it's not done right at any of those levels, it can potentially create a chilling effect. So I think that means that if you're interested in the telemedicine public policy side of things, you got to be talking to both local, state, and federal regulators. Clarence, Dr. Darkins, any further thoughts?
My thought would just be quickly as follows. I suspect, if it is, that the question is really very practical. If you're developing a telehealth program, then you really want to make sure, as I alluded to earlier, that you make sure you adhere to state and federal standards. So I apologize for sharing some of the complexity. One can't answer just overall, because it's a very general question. You have to first be able to be very clear what the design of your program is, what kind of modality it's using for telehealth. Is it actually providing consultation for telehealth? Is it providing care for telehealth? So you really have to start with program design, in my experience, being very clear what you're doing, why you're doing it. And then you can begin to engage and say, in terms of doing it in this manner, what federal regulations need to be kind of considered, and you also need to consider what kind of state regulations. So easy way to tap into it is various telehealth resources from some of the telehealth organizations which are out there can give you an overview. Sometimes in terms of cost, one has to take on expert guidance to be able to make sure and get advice around what's taking place. Things are not yet sophisticated enough to be able to have, if you'd like, a way in which you can just quickly go, in my experience, to one place. And it really also attests to the fact that if you're starting a program which is relatively small, it can be quite a high overhead cost in trying to deal with the issue of standard setting. So I think that this is, really gets to the core of some of the issues, and how standards impact on developing programs.
Great. Clarence, any thoughts?
Yes, very quickly, I would say a great starting place is your telehealth resource center. There are many spread throughout the country, roughly 2 dozen, I think, and they oftentimes can point you in the right direction. And I think another a great starting point is go and talk to your local representatives at your state house and in your health and human services and your commerce committees. Oftentimes, and education committees, oftentimes those three subcommittees play a pretty significant role in telehealth legislation, and also going to your Department of Public Health or your state to understand the operationalizing and interpretations of rules pursuant to any legislation that might be passed or active at both the state level and the federal level.
Great. Well, I know we've run over, and I would like to recommend if you post any questions to us in the program, someone will get back to you via email with the answer. Obviously, next time we need to spend a little bit more time answering some of these interesting questions. I didn't get through the question set I even created for the conversation today in terms of talking about innovation, return on investment, and the future of telemedicine. But I think, at least I've become a telemedicine nerd. I'm excited about this opportunity. And I so much want to thank Clarence Williams and Adam Darkins for their participation today. I want to thank the attendees for your interest in the topic. And obviously, we're going to have many, many opportunities to continue this conversation going forward. And I think, I've been around now, I'm closing in on 3 decades in healthcare policy. I think this is one of the most significant opportunities we have to work together. And it just, I find it energizing knowing if we do this right, how, again, at the end of the day, the patient is going to benefit and, the proper care is going to get out to the people who need it. So again, thank you, Clarence and Adam, for your participation. Both of them are traveling. I just want to really acknowledge your extraordinary efforts to help out. And those of you who, again, called in today, you can listen to a recording of this webinar. And please, jump on our webinar page at chqi.com, and you'll see there's actually probably 4 or 5 webinars that we have recorded. And please reach out to us as we continue to develop standards ourselves, hopefully honoring some of the lessons learned and some of the observations shared by our panelists today. So with that, I'll go ahead and wrap up the webinar. Thank you very much. Have a great day. Thank you, Adam. Thank you, Clarence.